In the mid-19th century, daily life in North American Adventist communities followed rhythms similar to those of many other rural and semi-urban populations in the country. The day began early, guided by natural light, manual labor, and a direct relationship with the land. Simple kitchens produced predictable meals based on grains, seasonal vegetables, preserved fruits, and homemade bread. The use of meat was common in society in general, but not always frequent in families with limited access to urban markets. Water was fetched from wells or streams, and the notion of hygiene was linked more to practical sense than to any consolidated scientific theory. In this scenario, illness was a natural part of daily life, treated at home whenever possible, out of necessity and custom. The medicine available during this period was marked by practices now considered aggressive or ineffective. Bloodletting, purgatives, and toxic mercury-based substances were frequently prescribed by doctors trained in respected schools. Furthermore, access to these professionals was irregular and expensive, especially outside major urban centers. Families learned to recognize basic signs of illness and resorted to rest. Simple infusions, water compresses, and dietary adjustments as initial responses. Trust was not placed in quick cures, but in the careful observation of the body over time. Among Adventists, this cautious stance took on its own contours from a broader cultural environment known as health reform. Popular publications advocating moderation in diet, fresh air, regular physical activity, and abstinence from alcohol and tobacco circulated in the United States. These texts did not originate within Adventism, but found resonance in religious groups attentive to personal discipline and the organization of daily life. Health came to be seen less as an isolated event and more as the accumulated result of habits maintained over the years. Adventist kitchens began to reflect this mindset in a practical way. Food preparation sought to reduce animal fats, strong spices, and excesses considered stimulants. Coffee and tea, widely consumed at the time, began to be questioned for their perceived effects on sleep and energy levels. Whole wheat bread, often locally ground, became common not because of modern nutritional ideology, but because of observed economy and digestibility. Eating ceased to be merely an act of satiety and became an exercise in daily mindfulness. Body care also extended beyond the table. Daily walks, agricultural work, and household chores were considered sufficient to maintain physical vigor. There was no talk of structured exercise, but rather of constant and functional movement. Bathing, although limited by infrastructure, was valued when possible, especially with cold or lukewarm water, a practice associated with revitalization and fever control. Compresses and damp wraps were used to relieve inflammation, following methods already disseminated by European naturalist movements. In this context, Ellen G. White appears in the records not as a physician, but as an attentive observer of daily life in her time. Her writings describe health practices already known and debated in American society, reinforcing the importance of regularity, simplicity, and prevention. She recorded personal and community experiences, frequently mentioning common mistakes, dietary excesses, and the effects of inadequate rest. These accounts circulated among Adventists as practical guidance, not as a scientific treatise, gradually influencing daily choices. As communities grew, the need arose for spaces dedicated to the care of the sick outside the home. Small sanitariums began to operate on principles different from conventional hospitals. The best-known example was the Battle Creek Sanitarium, which functioned as a center where simple diet, hydrotherapy, rest, and education in healthy habits formed the core of treatment. There, patients were observed over weeks, learning routines they were to take back home. The goal was not only to alleviate immediate symptoms, but to reorganize their way of life. Before modern medicine established its scientific foundations, Adventists practiced health as an extension of everyday life. There was no rigid separation between belief, work, and bodily care. The choices made at the table, in the rhythm of the day, and in the response to illnesses reflected a collective effort for coherence and stability in a world marked by medical uncertainties. This way of dealing with the body did not arise from laboratory discoveries, but from continuous observation and the attempt to live with fewer excesses, preparing the ground for changes that were yet to come. As the 19th century progressed, health practices among Adventists became more consistently organized, keeping pace with broader social transformations in the United States. The country was experiencing urban growth, railroad expansion, and the accelerated circulation of printed ideas. Newspapers, pamphlets, and home care books reached previously isolated villages. Inside homes, the routine continued to be marked by continuous work, but now intertwined with new concerns about longevity, efficiency, and self-control. Health ceased to be merely a response to illness and began to occupy a place in common conversations about the family as future. In this environment, food took on a central role. Empirical observation guided simple decisions. Heavy meals seemed associated with malaise, while lighter dishes promoted mental clarity and physical stamina throughout the day. The use of whole grains, porridges, and dried fruits became frequent, not due to scientific consensus, but because of repeated perceived results. Meat, when present, was reduced or reserved for specific occasions. Refined sugar, still expensive, was used sparingly, and homemade sweets were prepared sporadically, often linked to specific dates. Food preparation also reflected this growing attention. Time spent in the kitchen was seen as an investment in the stability of the home. Wood-fired ovens required planning, and bread fermentation was carefully monitored. Cooking without haste allowed one to observe textures, smells, and subsequent effects on the body. Mistakes were corrected over time, and recipes circulated among neighbors and relatives adapted to local conditions. Health, in this sense, was built collectively, through trial and continuous adjustment. Outside the domestic sphere, water held a prominent place. The therapeutic use of baths, showers, and compresses was inspired by naturalistic currents already known in Europe and America. The practice of hydrotherapy did not require complex equipment, only discipline and regularity. Cold baths were associated with stimulating circulation, while warm applications were used to soothe pain and inflammation. These methods were employed before any drug intervention, following the logic of interfering as little as possible with the body. Within this context, some figures began to organize and systematize existing practices. Among them, John Harvey Kellogg stands out, whose work at the Battle Creek Sanitarium broadened the visibility of the Adventist model of care. His approach combined clinical observation, dietary discipline, and strict routines of rest and exercise. Although his ideas extended beyond the Adventist environment, the daily life of the sanitarium reflected values already present in the communities, such as simplicity, regularity, and prevention. Patients were guided to understand their own bodies, recognizing limits and early signs of imbalance. The sanatorium environment functioned almost as an extension of ordinary life, only more structured. Meals were served at fixed times, with frequent silences encouraging mindfulness of the act of eating. Outdoor walks were part of the daily routine, as were mandatory rest periods. There was no rush in recovery. Time was considered an essential element of treatment. This logic contrasted with the conventional medicine of the time, which sought rapid, often aggressive, interventions to suppress immediate symptoms. Ellen G. White's influence remained present as a historical record and observation. Her writings continued to circulate, reinforcing practices already in use and warning against common excesses of the period. She described, for example, the effects of prolonged work without rest, irregular eating, and neglect of sleep. These accounts were read in family and community gatherings, functioning more as collective memory than as technical instruction. Authority came from shared experience, not academic titles. Meanwhile, American society was beginning to witness the first scientific advances that would later redefine medicine. Theories about germs were still being debated, and surgical anesthesia was a recent innovation. During this historical period, Adventists continued to practice health as part of their daily lives, relying on predictable habits and a gradual understanding of the human body. This was not about opposing scientific progress, but about a practical way of living while that progress was still being consolidated. Thus, before laboratory tests and standardized medications became commonplace, Adventist healthcare remained anchored in daily observation, disciplined repetition, and adaptation to local circumstances, paving the way for an inevitable encounter with the slowly approaching modern medicine. At the end of the 19th century, daily life in the United States was undergoing a gradual, silent process of reorganization. Homes, still simple for most of the population, began to incorporate practical notions of ventilation, regular cleaning, and a clearer separation between rest and workspaces. Among Adventists, these changes were not perceived as a rupture, but as a natural continuation of habits already cultivated for decades. Opening windows in the morning, keeping regular meal times, and avoiding strenuous activities at night were part of a domestic discipline that was transmitted more by observation than by formal instruction. The care of the sick remained largely the responsibility of the family. Rooms were temporarily adapted to allow for silence, air circulation, and access to light. Rest was valued as a central component of recovery, and visits were limited so as not to disturb the environment. Simple foods, prepared according to the patient's tolerance, replaced usual dishes. Light broths, dry breads, and cooked fruits were introduced gradually, accompanying the gradual improvement. This practice of continuous observation created an intimate relationship between the healing time and the rhythm of the house. The lack of effective medications made prevention even more crucial. Avoiding excessive fatigue, respecting rest periods, and maintaining regular sleep patterns were considered decisive factors in getting through periods of intense work or seasonal changes. Winter, in particular, demanded extra attention. Poorly insulated houses and irregular heating favored respiratory illnesses, and the common response involved moderate dietary reinforcement, protection against drafts, and reduction of outdoor activities. There was no expectation of absolute control of the disease, but a constant effort to reduce its frequency and severity. During this period, Adventist health was also expressed through discrete social choices. Abstaining from alcoholic beverages and tobacco, widely consumed in society at the time, produced visible effects on community dynamics. Social gatherings tended to be shorter, held during the day, and centered on conversation, reading, and simple meals. This moderation was not proclaimed as a public virtue, but recognized internally as a factor in physical and mental stability. Health was perceived as something sustained by small, repeated decisions, not by isolated gestures. Meanwhile, the institutional medical field was beginning to reorganize. Medical schools sought to standardize curricula, and professional associations attempted to establish minimum practice criteria. The creation and strengthening of the American Medical Association symbolized this movement toward standardization and scientific recognition. For many Adventists, this process was observed with caution and interest. There was respect for the emerging technical training, but also recent memory of aggressive treatments that had caused more harm than good. This cautious approach did not hinder learning. Methods considered useful were gradually incorporated, provided they did not contradict accumulated practical experience. The more systematic use of symptom records, for example, helped families and caregivers identify patterns of improvement or worsening. Noting fever, appetite, and sleep times made monitoring more precise, even without advanced instruments. This attention to detail reflected an already present mindset that the body needed to be understood over time. Children's education also played an important role. From an early age, they were involved in household chores, outdoor work, and predictable routines. The goal was not deliberate physical training, but gradual adaptation to exertion and rest. Playing outdoors, walking long distances, and participating in food preparation created familiarity with one's own body and its limits. Health, in this context, was not a separate topic from education, but an implicit part of daily life. With the growth of cities, some new challenges arose. Population density increased, and with it, sanitation problems. Adventists who moved to urban areas needed to adjust practices that were previously common in rural areas. Access to clean water, waste disposal, and adequate ventilation became more complex concerns. Even so, the response followed the same logic: observation, adaptation, and a preference for simple solutions whenever possible. As the 20th century began, scientific medicine started to offer more consistent answers to old ailments. Vaccines, antiseptics, and more precise diagnoses slowly emerged. Adventist health practices, formed before these discoveries, did not disappear. They continued to coexist, serving as a daily basis upon which new interventions would be evaluated and integrated, marking a period of silent transition that was still unfolding. At the beginning of the 20th century, the presence of scientific medicine became increasingly noticeable in American daily life. Hospitals began to expand, laboratory tests began to guide diagnoses, and standardized medications emerged as promises of more direct control over disease. For many religious groups and rural communities, this transformation was received with expectation, but also with caution. Among Adventists, the new scenario did not negate decades of domestic practices, but demanded a process of careful evaluation, guided by experience accumulated over time. Daily life continued to be organized around predictable routines. Even with urban growth, many families maintain regular meal, rest, and work schedules. Simple food, based on grains, fruits, and homemade preparations, remained a benchmark of stability. The use of new industrialized products, which were beginning to appear in markets, was observed with curiosity, but not always adopted immediately. Trust still resided in what was known, tested, and repeated for years without major interruptions. When illnesses arose, the initial response rarely began in the doctor's office. Rest, dietary adjustments, and environmental care remained the first measures. Only when symptoms persisted or worsened was external help sought. This sequence was not the result of absolute distrust in modern medicine, but of a consolidated habit of observing the body before intervening. Illness was understood as a process, not as an isolated event, and time continued to be an essential component of recovery. Adventist sanatoriums, already established at the end of the previous century, came to occupy an intermediate position between the home and the modern hospital. In these spaces, traditional methods of care coexisted with new medical techniques. Controlled diets, hydrotherapy, and rest were combined with more precise examinations and systematic clinical observation. This coexistence of practices reflected a broader transition in American society, in which the old and the new shared the same space out of practical necessity. Health education continued to be transmitted informally. Books, periodicals, and personal accounts circulated among families, reinforcing the importance of moderation and regularity. Reading was part of the nightly routine, and many of these texts dealt with topics such as digestion, fatigue, and domestic hygiene. There was no sophisticated technical language, but accessible descriptions that connected common symptoms to daily habits. This knowledge did not replace emerging medicine, but it offered a frame of reference for everyday decisions. During this period, the writings of Ellen G. White remained relevant as historical documents from a previous generation. Her observations continued to be read as records of experiences lived in a time of limited resources. They served as a collective memory, recalling practices that had sustained communities before scientific consolidation. Reading these texts did not prevent the adoption of new treatments, but helped to contextualize them within a tradition of prudent and gradual care. For Adventists of that period, health was not defined by rejection or full acceptance of modern medicine, but by selective integration. Treatments considered useful were incorporated, while excesses and aggressive interventions still aroused caution. This stance reflected a historical understanding. For a long time, survival had depended more on consistent habits than on quick fixes. The memory of this recent past influenced how the future was received. With the advancement of public sanitation policies, hygiene campaigns, and vaccination, many practices previously restricted to the domestic environment became widespread social norms. Regular cleaning, water and waste management, and adequate ventilation ceased to be individual choices and became integrated into urban life. For Adventists, these changes confirmed old observations rather than introducing entirely new concepts. Daily life adjusted without abrupt disruptions. Throughout this process, Adventist health practices before modern medicine revealed themselves less as a closed system and more as a set of habits shaped by necessity, observation, and time. It did not arise in opposition to science, but in a period when science was still seeking its own foundations. When modern medicine finally established itself, it found communities already accustomed to thinking of health as an inseparable part of daily life, closing one historical cycle and opening another that would continue to develop. Before modern medicine established itself as a scientific benchmark, Adventists dealt with health in a practical, everyday, and observational way. Their choices were shaped more by repeated experience than by abstract theories, more by the body's rhythms than by the promise of quick interventions. Simple diet, rest, moderate work, and attention to the environment formed the silent set of habits that sustained entire communities during a period of great medical uncertainty. This historical legacy not only explains how they lived, but reveals how they thought of health as an inseparable part of everyday life.